présence. On se retrouve aujourd'hui pour la troisième partie ou la troisième épisode de Capsule Radiologie, toujours présenté par notre cher docteur Harras Fatima Zahrae, qu'on la remercie infiniment au nom des organisateurs de cette réunion pour tous ses efforts et pour aussi toutes les présentations hyper intéressantes. Merci beaucoup, Fatima Zahrae. Et pour commencer, je vous serve la parole. Merci.
Merci beaucoup. Merci à vous aussi pour cette initiative. Et je suis très heureuse d'être parmi vous. So we will begin. I hope that you will enter this application so that we can dive into the case that we will have today. If you selected the code, you can just press this emoji so that I can know that you're here. There's also a QR code. I'll wait just for 2 minutes or so that I can begin my presentation. It's more fun to participate and there's no judgment here. You can select whatever answer you want and nobody will see it. We're doing this just for fun and to learn more. So at 43, we will go into the presentation. If you log out during the presentation, there is a bar here, so you can know where to go and what code you will type. You will see this during all the presentation. Now we will debut. We'll just begin with a nice break-in question. How was your day? Nice. Well, I hope that the ending of it will be interesting too. So let's go. Well, we will begin with a little introduction about me. I'm a 7th-year-old medical student at Abu Qasis. I'm deeply passionate about medicine and dedicated to helping others. So, of course, if you need anything, you can just ask me. And I have several certificates and accomplishments that I've done online and some conferences that I've been to in Morocco, like this one breast imaging interventional workshop, and here's from another kind. And now we will begin. So I have a question for you. Why don't medical students take breaks? You can answer here. Those are some meaningful answers. No time to take a break, pressure, yeah. dedicated to helping others. That's good. Okay, we have an answer here. Because the moment you take a rest, you forget everything you learned in the past 3 hours. Now we will begin. So we have the case of today is about a 24 years old patient who came with an appendicular syndrome. It means that he has pain and a defense of the right iliac fossa plus a fever. Our question is, what is the first radiological examination that you will request? You can answer here. So remember, he has an appendicular syndrome. What will you do first? Mm-hmm. Yeah, we have 6 participants. Mm-hmm. Nice. Yes, that was the right answer. So we will do the abdominal ultrasound. We've done it, but unfortunately, it doesn't show a visible appendicular structure at the level of the right iliac fossa. It shows a small amount of intraperitoneal infusion and a wall thickening of the terminal ileum. So my question is the ultrasound sufficient to rule out the diagnosis of appendicitis? You can answer here. For those who doesn't really understand what I've said, I can repeat it in French for you, no problem. L'échographie abdominopelvienne ne montre pas de structure appendiculaire visible au niveau de la fosse iliaque droite et montre un épanchement intrapéritonéal de faible abondance avec épaississement pariétal de la dernière anse iléale. Now you can answer our question. Nice. That's good. So the right answer was no, it's not sufficient. We can't say that this patient does not have appendicitis just after doing the ultrasound. So here is the answer. The ultrasound is not sufficient to eliminate the diagnosis of appendicitis because it has many limitations: retrocecal appendicitis, obesity, and other. So what do you propose? Will you refer your patient to a surgeon for surgery? Will you provide a symptomatic treatment? Will you perform an abdominopelvic CT scan or do nothing? Mm-hmm. So we have different answers. Well, the right answer is in green, is the green one. This one. We will perform an abdominopelvic CT scan. So we will do an abdominopelvic CT scan using anterography technique. What it means, an anterior CT is a CT scan performed after good filling and distension of the small bowel loops with diluted mannitol to better visualize abnormalities and digestive wall thickening. So now we've done it. We've done this anterior CT scan. This is what we found. You can see here the actual sections. And here you have the coronal reconstructions. I'll let you see this for a moment, and then we will go to the question. So the question will be, what does the intercity not show? So now you've seen the intercity that we've shown you. And now you should tell us what you did not see. So, was there a wall thickening of the last loops of the small intestine? Was there an infiltration and comb-like appearance of the perilesional fat? Was there a target sign of thickening, submucosal edema? Was there a sign of appendicitis? What you did not see at the CT scan. For those who does not really understand English, I can صراحة tell you this in French. Wall thickening, c'est l'épaississement pariétal. Target sign, it means aspect sensible. And if infiltration with comb-like appearance of the perilegional fat is infiltration avec aspect peigné de la graisse périlésionnelle. So something that you did not see at this interior CT scan. Mm-hmm. We will see what is the right answer. So it's the sign of appendicitis. We did not see in this CT scan. We did not find the signs of appendicitis. Now we will look more carefully into this. So this is the wall thickening of the last loops of the small intestine, as you can see. And then here we have in the yellow arrow, we have the target sign, submucosal edema. And here in the green arrow, we have the infiltration with comb-like appearance of the perilegional fats. We will see this in the second one also, in the reconstruction. So here in the this arrow, this blue arrow shows us the wall thickening here, the wall thickening of the last loops of the small intestine. And here, the green arrow is the infiltration with comb-like appearance of the perilesional fats. Here. So we have here the next question. What is the first diagnosis to consider? Is it ulcerative colitis, c'est le RCH, or Crohn disease, or is it appendicitis, or is it peritoneal tuberculosis? Mm-hmm. So the right response is Crohn disease. In the CT scan, we've seen that there was a normal appendix, and but the diagnosis, we cannot eliminate the diagnosis of appendicitis. So after seeing the CT, we had the signs of the Crohn disease. So now we will search for the activities, for the activity signs of Crohn disease, because it's very important to guide the therapeutic attitude. So which sign is not a sign of activity of Crohn disease on a CT scan is not. Is it the target sign, submucosal edema thickening of the wall? Or is it infiltration with comb-like appearance of the perilesional fat? Or is it the digestive stenosis or intraperitoneal infusion? Je vais dire la même chose en français pour les gens qui ne comprennent pas beaucoup l'anglais, surtout en radiologie, c'est plus difficile. Donc, target sign submucosal edema of the wall thickening is l'aspect insible, œdème sous-muqueux de l'épaississement pariétal. Infiltration with comb-like appearance of the perilesional fat is une infiltration avec un aspect peigné de la graisse périlésionnelle. A digestive stenosis is une sténose digestive. Intraperitoneal infusion is un épanchement intrapéritonéal. So now you can choose. So all of we have here 3 signs that indicates that we have the Crohn disease and its on activity. But one sign that doesn't really indicate the activity of the Crohn disease, it's a chronicity sign, not an activity sign. So think wisely and think carefully so that you can have the right answer. Okay. So here are the answer. So the digestive stenosis is a sign of the chronicity, is a sign indicating the chronicity of Crohn disease. The other ones are for the activity. So a digestive stenosis can be inflammatory or sickly. Now the diagnosis was a Crohn disease with signs of activity. That's what we found. Now we will talk about Crohn disease, because the last time you told me that you would prefer, I saw it on your feedback form. I saw that a lot of you suggested that we do like a recap for the pathology that we will discuss in the radiological findings. So now we will go into discussing and learning more about the Crohn disease. So what is the Crohn disease? The Crohn disease is an inflammatory bowel disease that causes chronic inflammation in the bowel anywhere along the gastrointestinal tract. This is the gastrointestinal tract from the mouth all the way to the anus. And we have an infected bowel between areas of active disease called skip lesions. So all the way you will not find all of this having inflammation on it. You will just have parts of it will have inflammation, and other parts will be intact. So it's unlike its cousin, ulcerative colitis, which only affects the large intestine, and you can't find skip lesions on the ulcerative colitis. So now we will dive a little bit more into the physiopathology, just to know a little bit more about this Crohn disease. So here we have the ulcerative colitis is an autoimmune disease triggered by, so it's more triggered by your own cells. It's like your own cells just attack you. It's like your cells attacks you. So they are not triggered by something like a pathogen or something that is outside of your body. They are triggered by themselves. But the Crohn disease is not an autoimmune disease. It's an immune-related disorder. It means that it needs a pathogen to just like be there, so that it can trigger your own cells, and then they will create an exaggerated reaction. for this pathogen. And just to answer a question, I don't know if you have the same question at mind, but I was like, our body is supposed to help us, so it's supposed to protect us from pathogens. So it's normal that it will react. But in the Crohn disease, we have a large and uncontrollable response to the point that it leads to the destruction of the cells in the gastrointestinal tract. So it's more like a dysregulated inflammatory response. And they found that it can be related to genetics. Actually, they found that there was a mutation of the NO2 card 15. And if you have this gene, it means that you have a higher risk of having the Crohn disease. So that's why you'll find the patients with family members that have Crohn disease are much more likely to develop the Crohn themselves. And also, you will find the Crohn disease, especially in the patients who's between 20 and 40 years old. And here, just that you can remember that it can be between the mouth and the anus, the inflammation. Now we will see a part of the video osmosis because it was so interesting and I wanted to show it to you. So here we'll begin. So that was the part of the video that seemed so interesting. I don't know if you can hear it. It's okay. We will repeat this in the presentation. So here we have a presentation. So here we will understand why the patient will have diarrhea plus blood in the stool and will have a malabsorption, the malabsorption. So here, when the cells are distracted in the large intestine, it prevents them from absorbing the water. We will call it water. It prevents them from reabsorbing the water. So what happens is that the water is just there, and our large intestine will just let the water flow, and that's what will cause the diarrhea. And the blood is because, as we've seen in the video, there was ulcers, and ulcers will just cause blood, and we will have the blood with the diarrhea in the stool. Also, we have the small intestine. So if the cells in the small intestine is damaged here, we will have these cells will lose their ability to reabsorb nutrients, because here we have the reabsorption of the nutrients, and that will cause the malabsorption issue. Will cause them malabsorption issues. That's why they will have all of this. So now, I prefer to give you the symptoms as a quiz, not as something that you will just see and forget about it afterwards. So now choose what are the symptoms for the Crohn disease. Is it the non-bloody diarrhea? Is it the weight loss? Is it the bloody diarrhea? Is it the fever, malaise, and anorexia? Or is it the vomiting pain? You can choose more than one answer. Oh, you remember. But you have to choose a lot of answers, not just one. Because there's a lot of symptoms in Crohn disease. Just remember what you've read in your med school or else and choose what seems appropriate to you. Mm-hmm. So just weight loss and blood diarrhea? Okay. We will see what are the right answers. So the right answer was all of this. Because in Crohn disease, we can have bloody diarrhea and we can have a non-bloody diarrhea. And non-bloody diarrhea is more common. Because in Crohn disease, usually you find a non-bloody diarrhea. But in ulcerative, in the RCH or ulcerative colitis, you will find bloody diarrhea. Okay, so here in Crohn disease, you can find all of this. We have a lot of a big range of symptoms that can appear. So you have to keep in mind all of these symptoms. Okay, we'll get into the. So here we have a message that you should remember, an important message. So do not use the presence of blood in stool alone as a deciding point to pick UC over CD. UC is ulcerative colitis, CD is Crohn disease, because both of them can have blood in the stool. So you can't decide based on the symptom. So here, another question for you. So for the people who are smokers, does it increase the risk of the Crohn disease or it decreases the risk of the Crohn disease? Okay. Where are the others? If you want to join, just type this and then enter this code.
A Muslim that celebrates Christmas.
Okay, it increases the risk of CD. Yeah, it increases the risk of Crohn disease. So smoking, in the case of Crohn disease, it increases the risk. And in the case of ulcerative colitis, it decreases the risk. So this is the case for the UC, the ulcerative colitis. But here, for the CD, it increases the risk. Here we have some signs that you will find while examining the patient. So what will you find? Will you find an aphthous ulcerations? Will you find a palpable mass in right iliac fossa? Will you find abdominal pain in the left lower quadrant? Or a perianal fistula? Or clubbing? Clubbing, c'est l'hypocratisme digital. You can see it here. Choose your answers. It's getting harder. Less people are answering these questions. Don't worry, as I told you, you can feel free to answer whatever you want. Nobody can see what you will answer. So we'll go into the right ones. Those were good guesses. So it's all of this. In Crohn disease, we can have an aphthous ulceration, we can have a palpable mass in right iliac fossa, and we can have perianal fistulas. Also, we can have clubbing. Clubbing, so for most of the people, when they see clubbing, they will think about cardiac diseases and pulmonary diseases. But don't forget to think about gastrointestinal diseases, because it can also cause clubbing. So here we have another case. So if you have a young patient who has diarrhea and he tells you that it's sometimes bloody, what will be the most appropriate next step? So will it be the fecal calprotein or the ultrasound or the colonoscopy? Okay, we have different answers. Okay, so wanna know the right answer? The right answer is the fecal calprotectin. Why? Why we will do this? Because we will do this to differentiate between the irritable bowel syndrome and the inflammatory bowel diseases. So when we say the inflammatory bowel diseases is Crohn syndrome and ulcerative colitis. When we have a young patient and he has a diarrhea, we will not go into colonoscopy because it's invasive, and we don't do a colonoscopy as first thing when we have a young patient. So the most appropriate test to do is the fecal calprotectin. If the fecal calprotectin is high, we will say that it is the inflammatory bowel disease, because it will be high while we have inflammation. And if it's normal, then we will say that it is an irritable bowel syndrome and treat it as so. Now we have a second case. We have an old patient who has bloody diarrhea. So what will you do? Will you do a fecal calprotectin for this patient, or will you do a colonoscopy? Mm-hmm. Okay. So 3, 2, 1. And this is the answer. It's colonoscopy. Why? Why we will choose to do colonoscopy? Because usually when you have an older patient who has 45 years old, 50 years old, especially 50 years old and above, we will think about doing the colonoscopy because the first diagnosis that will cross our mind is the cancer. So you need to do a colonoscopy to eliminate this diagnosis or to confirm it. This is the third case. So when you have a young patient having pain and defense of the right iliac fossa with fever, what will you do? Well, it's the same case that we had. You need to know this one. Okay. Well, that was the right answer. Happy that you guessed it. Now, what is the most definitive gold standard investigation that leads to a diagnosis of Crohn disease and ulcerative colitis? The gold standard. Like, how can you confirm? Mm-hmm. Okay. 3, 2, 1. Yes, it was colonoscopy. Why? Why colonoscopy? We talked about fecal calprotectin. We said that we can differentiate within the irritable bowel syndrome and the inflammatory bowel disease. But here we need a gold standard investigation, an investigation that will confirm for us that is an inflammatory bowel disease. And the only investigation that can confirm that is the colonoscopy plus the biopsy. Biopsy will show us if it is Crohn disease or ulcerative disease or ulcerative colitis. But the colonoscopy is the gold standard in those two pathologies. Here we have the colonoscopy plus biopsy in Crohn disease. And I need you to answer this. What the colonoscopy and biopsy will show you. Here we have different suggestions. We have the granulomas, crypt abscesses, deep transmural ulcers, skip lesions, and cobblestone appearance. You can answer more than one, not just one. More than 3. I'm giving you hints. More than 3. Okay. They told me that it's impossible to select more than one answer. So that's okay. I'll just say that you selected all of the answers, all of the correct answers. Okay, so we have the granulomas. the deep transmural ulcers and the skip lesions, and also we have the cobblestone appearance. Here you have what you will see, and here you have why they call it the cobblestone, because it's like this. It's like the cobblestone. Here we have some radiological findings, so you can choose what you will find in the Crohn disease. Will you find a contour string sign? Will you find a rose thorn ulcers? Or loss of ostration fistula? Mm-hmm. Okay, that's good. I'm sorry about the problem that you can choose more than one answer, but that's okay. At least you know what you will choose, so that's good. For these questions, one of them, for these responses, one of them is false, but it's okay. In the Crohn disease, we find cancer string sign. It's like you have stenosis and you have the contrast here. So you can see here that there is a stenosis, and they call it a cancer string sign. And here we have the rose thorn ulcers. So here, as you can see, we have ulcers here that appears. I don't know if you can see it, and those ulcers can turn into fistulas. For the loss of ostration, no, we don't find it in the Crohn disease. We find it in the ulcerative colitis that attacks only the colon. But in Crohn disease, no, we don't find this one. Here we have the treatments. So here I find it in the Oxford Handbook. So what it means having a mild attack of Crohn disease, it's symptomatic but systematically well. So you have a patient who has symptoms but who's stable and who's doing well. For this case, they give prednisolone 30 milligrams per day. PO means per month. Per mouth. He eats the medicine for 1 week. Then they give them 20 milligram per day for 4 weeks, and you can see in clinic after 3 weeks your gastro or whatever medical specialty you're with. So if the symptoms resolve, then they will lower the dose of prednisolone by 5 milligrams every 2 to 4 weeks, and they will stop steroids when parameters are normal. So the objective of today, I didn't tell you this at first because you had to guess the pathology after seeing the case. The objectives of today was to differentiate Crohn disease from other causes of acute abdominal pain using imaging evidence. And the second one was identifying suitable imaging technique for diagnosing Crohn's and other gastrointestinal disorders. And the third one was utilizing radiological insights to direct Crohn disease management and minimize unnecessary intervention. You have to know that in Crohn disease, even if they do a surgical, if they don't have a choice and the medicine doesn't work, the medical treatment doesn't work, they will go into surgery. but unfortunately, removing a part of the intestine or the intestine will not resolve the problem, because it can be recurrent, and you have the inflammation from the from the mouth to the anus, so it's impossible to remove all of this. So even if so the surgical procedure is not considered as a curing treatment. And here we have our take-home messages. So for young patient with appendicular syndrome, consider using ultrasound as the first radiological exam, and don't jump to conclusions based on initial tests. Further imaging was crucial in our case. The most definitive gold standard investigation that leads to a diagnosis of the inflammatory bowel diseases is colonoscopy, as we've seen. If the patient is young with Crohn disease or ulcerative colitis features and bloody diarrhea, the most appropriate next step is fecal calprotectin to differentiate between irritable bowel syndrome and inflammatory bowel diseases. And if the patient is old, cancer is suspected, so do colonoscopy. And as we conclude, I want to extend my heartfelt gratitude to the two remarkable mentors who have greatly enriched this presentation with their wisdom and expertise, because the images was provided by them, and the case that we've done at first was provided by them. So thank you for Dr. Nadia Sqali Husseini and Dr. Asma. And of course, while mentors light the path, it's your steps that create the journey. So believe in your street. So here is the form. I will greatly appreciate that you go into the form and give me your feedback so that I can make better presentation for you. And thank you for being here with us and listening to all of this till the end. And I hope that you learned something new today. Thank you. I will give you the Google form. So I can send it to you here. And I really appreciate having your feedback. It really helps my presentation, and it really helped me to create better things for you. And thank you a lot for being here. And I think so. We finished.
Merci également pour vous, chère Dr. Fatima Harras.
Avec
C'était une
plaisir.
très belle présentation. Merci.